My topic will be so basic, and it's a topic of public interest. A lot of the people in India are hypertensive. You know that nearly 35 crores are the hypertensive and nearly 30 crores are pre-hypertensive. So if you combine that, nearly one third to one fourth of the Indians are the hypertensive. So this hypertension is characterized by the persistently and the chronic high rise in your blood pressures, or the systolic or the diastolic, or the both. The idea is not clear in most of the cases. That's why we consider them as essential hypertension or the primary hypertension in nearly 90% of the cases. We are fortunate to have the secondary cause in just 5% of the cases. Where if you treat the secondary cause, the lifelong antihypertensive medication is not advisable at all. And if you see this slide, they showed the different numbers of the to define them as a normal or abnormal or grade 1, grade 2, etc. And what's different in the Indian hypertensives from the Western hypertensives is the normal levels. So in the Western population, they say that even 120 to 129 of systolic and 85 to 89 of the diastolic are the normal. But whereas our people, the normal blood pressure is systolic less than 120 and the diastolic less than the 80. So any BP more than 121 of systolic and more than 81 of diastolic is either hypertensive or the pre-hypertensive. So that should be keep in your mind. So in that way, most of our people here are either hypertensives or the pre-hypertensives. See, 1 in 5 young adults have high blood pressure. It's a very high incidence. The prevalence is also very high. And hypertension number comes alone. So most of the people, the hypertension, common symptom of the hypertension is no symptom at all, asymptomatic, in nearly 90% of people. But if they get the symptoms, they are in some complication. So hypertension and cardiovascular disease is a very common deadly trio. So it develops the atherosclerosis and destabilizes your plates and precipitate acute coronary events. It is important to achieve and maintain the good blood pressure control. It's very easy to say, but very, very difficult to achieve your target blood pressure of less than 120 to 80 most of our population. So the goal therapy is very clear to reduce the mortality of this hypertension. And you have the primary prevention and secondary prevention, the tertiary prevention. So all the primary preventive measures are your lifestyle measures. It's very easy to say again to make the lifestyle changes, but it's very, very difficult to avoid your calorie diet, high fatty diet, high saturated diet, and high trans fats. And physical inactivity itself is a big risk factor. So unfortunately, most of our people are not getting more than 15,000 steps a day. Smoking, so it's very, very important risk factor for the atherosclerosis. In any form of the smoking, whether the active smoking or the passive smoking, and excess alcoholism, because J curve will be abolished once the people are on excessive drinking. And the stress is very common, now starts from the LKG. So IIT studies and NEET studies, etc. So no playgrounds in the schools. So the stress and strain is very common. So that is itself a very big risk factor. And genetical factors. So those people who are genetically more prone to have the hypertension, if the environmental factors are there, so definitely they will get the hypertension. So as I told you that when you are treating the hypertension, so don't treat the hypertension alone, because most of the hypertensions will have the associated comorbidities like your diabetes or dyslipidemia, obesity, etc. So unless you control the comorbidities along with the hypertension, so these people will reach the stage of either coronary vascular disease or cerebrovascular diseases or coronary chronic kidney disease. So these diseases, the numbers are very, very high. What is very important here is the systolic BP more than 120 was associated with the increased risk of CV events, coronary artery disease, and the stroke. So the take-home point here is when the blood pressure, systolic blood pressure is more than 120, they are at high risk of getting the complications. So don't think that 140 by 90 is a normal, but you should think that less than 120 by 80 is the normal blood pressure for all of us. So the BP control is of paramount importance in decreasing the cardiovascular risk. But unfortunately, we are not making our people hypertensive individuals to reach the stage of 120. The hypertension chronic kidney disease is a very deadly deal. It is recognized as the biggest contributor to the global burden of the disease. common in CKD, and if you don't treat it, so definitely they will go into the extreme renal disease, where on the renal replacement therapy is the option there, either the dialysis or the transplantation. The patient with advanced CKD disease not under dialysis are very high risk of the syphilis, because most of the nephrology patients they die in the hands of the cardiologist because of the premature atherosclerosis or IHD or class. So the optimum BP control is very, very essential to have a normal kidney function. The podocyte damage is very common in hypertensive individuals. So there will be the damage, there will be the stress, there will be the glomerulosclerosis, and finally there will be the end-stage kidney disease. CKD as a risk factor for the cardiovascular disease. So it is the most common cause of death, as I told you earlier, and is independent risk factor for the cardiovascular disease. And decline in the GFR correlates with the CKD mortality. The lesser the GFR, the more the mortality. And microalbuminuria also will have increased risk of cardiovascular disease. So far, microalbuminuria means it's a marker of the nephropathy. Nowadays, it's not only a marker for the nephropathy, but also a marker for vasculopathy. So macroalbuminuria means more risk of the cardiovascular disease. So now coming to the topic of the proper calcium channel blockers, very, very important drugs. They are the best drugs to reduce the hypertension. So we have the ABCD drugs like angiotensin converting enzymes, ACE inhibitors, or ARBs, and beta blockers, calcium channel blockers, diuretics, other drugs, etc. Among all the antihypertensive drugs, calcium channel blockers are very good drugs to reduce the blood pressure very effectively. So you can divide these into the 4 generations. We are using the 3 molecules very often. Is the dipeptidyl the shortest acting drug like DP, maybe 8 hourly or 12 hourly. Mostly we use it in the CKD population. Dipeptidyl control release 20 mg, etc. But most of the times we use the amlodipine as a 2.5 mg or 5 mg or 10 mg OD, and then you have the cilindipine, so also 10 mg, 20 mg. Now that molecule of the today's interest is a penidipine. How it is different from the other calcium blockers? To explain it. See, as far as the calcium channel blocking is concerned, it disrupts the flow of the calcium to the calcium channels. You have the different types of the channels are there: L type, N type, T type, and also PQR. So far, we have the 3 drugs: amlodipine, will act on the only N type; cilindipine acts on the L and the N. Now the viridipine, it also acts on the L, N, and the T. See, the L means long lasting, N means neuronal, the T means the transient. If you see this, when you block the L channels, so you are having more cardioprotection. When you block the neuronal channels, you will have the more neuroprotection. When you block the T channels, you will have the more nephroprotection. So this molecule, viridipine, which acts on all the 3 channels, so you will have the neuro, nephro, and cardioprotection. In the L-type channels, how they act? See, the L-type channels, they cause the cardiac muscle constriction, the vascular smooth muscle contraction. So what will happen? They will increase oxygen demand, increase the heart rate, and increase the blood pressure. So if you block them, then you have the decreased oxygen demand, you will cause that bradycardia, then you have the reduced blood pressure. And the N-type channels, so these are sympathetic nerve endings, the noradrenaline will be there. So these noradrenaline levels will act on the 3 levels. One is on the vessels, then the heart, the kidney. So by blocking these N-type channels, you will have the cardiac protection, you have the vascular protection, also you have the renal protection. So the T-type channels, they act on the adrenal glands. So here the aldosterone production. You know the aldosterone production, more and more aldosterone production means more sodium reabsorption, so fluid overload. So obviously the causes of fibrosis in the kidneys and more nephro destruction. But when you block these T-type channels, so you will have the nephroprotection also. So they not only act on the adrenal glands, these T-type channels, they also act on the kidney, on the afferent and the efferent. So they cause the constriction. So once there is an afferent and efferent arterial constriction, you are causing more and more intraglomerular hypertension, more and more hyperfiltration. So that will lead to the damage to your kidneys. So there will be increased glomerular pressure, increased proteinuria, and more inflammatory. So when you block this, so you will have a dilatation of your afferent and efferent arterioles, and you will have the nephroprotection. So this is the viridipine, a novel calcium channel blocker. So they act on the L and hence the triple channel blocker. So it causes the blocks the N and side. So it has a potent anti-hypertensive and anti-angiogenic. So this is a high vascular selectivity and the protective effects on the vascular endothelial cells. Renal protective effects are also seen, antioxidant effects. And the beauty of this molecule is it enhances the nitric oxide production. See, the nitric oxide is a good vasodilator. So the more and more nitric oxide means more vasoprotection. So the same thing here, the conventional calcium channel blockers, where the benefit they have the good directly and indirectly blocks these channels, so you have the good protection. In the same way, the norepinephrine levels will be blocked by using this benefit, so that you will have the vascular protection, cardiac protection, and the renal protection. And in the same way, the benefit they also act on the T channels, so they will have the nephroprotection and also dilates these two arteries, so causes less hypertension in the glomerulus, so less fatal edema. So high vascular selectivity, so there's 19 times higher than that of the amlodipine, that's the commonest calcium blocker we often use it. So 14.4 times higher than that of the nifedipine. It's a vasodilator, vasoprotective effects because of the enhanced nitric oxide levels. See the benefits on the podocytes, it reduces the podocyte damage so that no glomerular filtration secretion or sclerosis, so you will have a protection. So the nephropathy, again, it gives a good protection as far as the kidneys are concerned because it reduces the glomerular hypertension. What about the cardioprotection of the benefit, the clinical evidence? See this trial. So yeah, they have taken nearly 4,000 people. They have given the benefit plus angiotensin receptor blocker in some individuals, benefit plus beta blocker in some individuals, benefit plus diuretic in some. Because this combination is a very common combination they often use in our practice. So calcium blocker plus ER, calcium blocker plus beta blocker, and the calcium blocker plus the diuretic. So what happens when you use these benefit with all these combinations, found to be similarly effective in preventing the cardiac events. See, this trial shows you the elderly population. If you use this as a drugs, because in elderly population, antihypertensive or two drugs are very drugs of the choice in elderly hypertension. One is diuretics, especially indapamide, and the second one is calcium channel blockers. So elderly population they respond very well to the calcium channel blockers. Here, as for the age is concerned, 65 to 74 or more than 75, nearly 57 to 56% reduction in the blood pressure is noted. What of the safety and the tolerability? Very good. Overall incidence is good. Adverse reactions are very less than the 5%. Less the risk of the reflex tachycardia and the fatal edema because of your nephroprotection. Very few cases of the edema because it dilates for the afferent and the arteries, unlike the amlodipine, which dilates on the. This is the anti-ABC study. ABC means amlodipine to the beridipine changeover study. So all the regions, the people are on the amlodipine. Once you change to the beridipine, so what will happen? So the result is beridipine may have a greater efficacy than the amlodipine in reducing the blood pressure. So you are not doing damage or damage to these people who are on the amlodipine when you change the beridipine because it is more protective and more effective than the amlodipine. In the same way, if you add the amlodipine with the ARB or the beridipine to the ARB, the choice is in hypertensive patients treated with ARB and the CCP. Beridipine exhibits a better renoprotective effects than the other drug of this class like amlodipine. So it is more renoprotective when compared to the amlodipine. Also, even though you are using along with the ARBs. So the CPC study, this is your cilindipine. So the people on the cilindipine back to the changed over to the beridipine. So how they react. The potent antihypertensive effects of the beridipine compared to the cilindipine are beneficial effects on the renal function. High usefulness in hypertension complicated by the diabetes. So when the fellow is a diabetic and hypertensive, again a deadly duo where AS or ARBs are the initial drugs of the choice, but most of these people they need the combination therapy. Then the beridipine with ARB is a good choice in a diabetic hypertensive individuals. So beridipine when compared to the other CCPs, calcium inhibition with the 3-channel, so they block the L, N and also the T, long lasting nearly the 24 hours. Renoprotection is more when compared to the other calcium blockers because it acts for adrenal cortex, it acts on the kidneys, it acts on the vessels, it increases your nitric oxide levels. And the renoprotection is very good. Digestion of the afferent artery is seen in both here Failure edema is very, very negligible, and reflex tachycardia is also not there, and vascular selectivity is very good. Thank you very much for your patience.